Hello, everybody, and good morning. Welcome to the fifth and final in this series of webinars organised by Cancer Patients Europe as part of the European Week Against Cancer. Today is also World No Tobacco Day, and so congratulations to everyone working and campaigning on those issues. So it's an appropriate day for us to be discussing about how smoking cessation is a step towards a cancer-free environment. I'm Tamsin Rose and I'm the moderator of these webinars. They're all recorded and you will be able to find them on the Cancer Patients Europe's YouTube channel. We've already put up the webinar from Monday that's available and you'll be able to see the others very soon. Please watch again, share and distribute. We would invite you, for those of you who are active on social media, to use the hashtag EWAC 2024. That's for European Week Against Cancer. And that helps us to track the results and also your comments and your feedback on all of these. So what are we talking about today? We are going to be highlighting how the importance of stopping smoking. And this is not just for generally to make sure we've got a smoke-free environment, but specifically for cancer patients. We're going to be talking about the critical role that stopping smoking can play, both in improving the health outcomes and their quality of life, and their physical and mental health. And this is even important during palliative care, and we'll be discussing that throughout this morning. But first of all, I'd like to show you an image and then I'm going to ask you what your responses are. So first of all, let's see the image. And the image there we've got is we're going to show you 5 reasons to quit smoking after a cancer diagnosis. And I'd like you to just look at them for a moment and absorb them. This is what we're going to be talking about today. There are very clearly benefits. You'd imagine that, when somebody gets a cancer diagnosis, it may feel like the world has fallen in on them, but there is still 5 good reasons for people to quit smoking, to be supported to quit smoking after cancer diagnosis. So there we can see that there is a better chance of successful treatment. It has a clear outcome on people's health diagnosis. It also supports during treatment, it reduces the number of side effects. And again, this can range for anything such as infection, fatigue, and nausea. We know also that it will help people have a faster recovery. Often cancer treatment is very invasive. It's hard for the body to take. And if you can quit smoking, your body will heal faster. We also know that it lowers the risk of secondary cancers, which are the things that can complicate and make life a lot harder. And finally, it's very clear that there is an improvement in quality of life. So we've got 5 really good reasons to quit smoking. And what we want to do is we're going to ask you now, and we're going to create a word cloud. How do you feel after you've seen that? I think you've got some very clear, very powerful messages, both for clinicians and patients, about why in that sort of early moments of post-diagnosis and developing a care plan, that support to quit smoking should be front and center in what you do. But let's now see the word cloud. We're interested in finding out how you feel about the information we've just given you. Is it new information? Is it something that perhaps you already knew? Is it something that you think is already well known amongst either patients or clinicians? Is it something that you think is prioritized by clinicians? Because of course, when you've just got a patient in front of you who's just had a diagnosis of cancer, it's a really challenging moment, and there's a lot of information you need to share with them about what they can do and what's going to happen to them. It may not be top on your list of things to say or information to pass. Why stopping smoking should be a priority, and why you should be also integrating in your psychosocial support the kinds of things that we would offer people to help them quit smoking, because it's not an easy thing to do. So thank you for that. I'm starting to see some messages. People are saying it's important. It's never too late. This kind of information, it's both obvious, but it's a good reminder. It gives them hope and it incentivizes patients for change. So I think thank you very much for sort of giving us this feedback. That's why we wanted to start the webinar with this very clear set of messages. These reasons are why we're going to discuss what to do about this and how it works, because of course it's many cancer treatments and protocols are complicated. And to layer into that support for smoking cessation can also be a challenge. It's possible, and we're going to talk about that now. But thank you for putting in the word cloud why you think this is important, how you feel now that you can see those very clear 5 reasons. You know, innovation helps. It's never too late. So thank you very much. I think we'll now move on to our first speaker, and I'm delighted to introduce to you Dr. Mahdi Sheikh, a scientist at IAC and at the WHO, and he's going to give us some perspective. Dr. Sheikh, we've just seen those 5 reasons, and I'm convinced that's great. But in the broader perspective of cancer research and the work that we're doing in clinical, we often think that innovation is at the cutting edge of new medicines and treatment. But how can smoking cessation be part of that, yes, new approach to better quality treatment and protocols for cancer patients? Dr. Sheikh, please go ahead.
Thank you very much. Thank you very much. Yeah, amazing. I mean, seeing this photo, it's really powerful. So thanks very much for inviting me, and also for the participants. I would like to just say a couple of sentences about why it is important really to quit smoking and where we are standing right now. So you will hear from other participants about the topic. So we know that tobacco smoking causes at least 20 different types of cancer. And if you quit smoking, the risk for developing these types of cancer many of these cancer types will decrease compared to if you continue smoking. So this is well known. There is strong evidence. And in Europe specifically, 20% of the cancer deaths, meaning that every one cancer patient who dies from cancer is actually because of tobacco smoking. So you quit smoking, your risk will be decreased. But the problem arises when patients with cancer, we know that many patients with cancer still smoke tobacco, and that's the problem. As high as like 50% in some cancer types, like lung cancer patients, they still smoke at the time of diagnosis, and it is true about other cancer types, like 20%, 15% at least. So they keep smoking. And now here's the problem. So if you want to talk about the effect of quitting smoking after cancer diagnosis, we should address 3 levels, I would say. 1, at the level of patients with cancer, 2nd, at the level of healthcare providers, and 3, at the level of policymakers. So, patients with cancer, when they smoke and they get cancer, at that time, they feel that, okay, it's too late. I already got cancer, and let me enjoy these days, and I'm going through a very difficult time. So they think that it is too late and there is no benefit. This is one thing that we need to focus on. The second part is the physician part and healthcare providers who provide medical care to patients with cancer. It is strange and striking, if we see the evidence that less than half of healthcare providers who provide cancer care to patients, they even talk about smoking and they suggest smoking cessation to their patients. Like around 40% only suggest now, let alone support, let alone the infrastructure for quitting smoking. And that's striking, it shows us first the physicians, a lot of healthcare providers, they do not know what is the effect of quitting smoking. And now we will talk about that hopefully. And they haven't been trained to provide smoking cessation. This is another problem. But another problem is that, they think that it is already too much for the patient. They are going through hard time, the psychological stress, and why we stress them with smoking cessation, let them again enjoy this activity, whatever, and they think it is not useful. And then at the healthcare providers, policymakers, there is no infrastructure. Specifically, like in Europe, we see that it is strange that we don't see the infrastructure for smoking cessation. It is not integrated in cancer care. And a lot of that is due to lack of awareness, actually, and lack of funding. And this makes us responsible to provide the evidence to these 3 levels of stakeholders. So I would say now, what is the effect? Okay, we in the past decade at IARC, we collaborated with many scientists across different countries in Europe, in the United Kingdom, in Latin America. And we recruited a large number of patients with different cancer types who smoke at the time of diagnosis. And we follow them prospectively. Each year we collected data, we called these patients, their families, their healthcare providers to ask about their disease status, smoking status, and all the treatments. And we followed them for a decade, so almost a decade. We went forward with them. And the strange thing, I mean, the striking effect of smoking cessation is that it is more powerful than anything else you can do. If you want to provide a good cancer care, so it should be in your to-do list. I mean, to talk to patients about that and support your patients. Why? Because what we see, and this is true across different cancer types, it's not lung cancer, we see that if patients quit smoking, even if you consider like all stages of cancer, the treatments and everything, they improve in median survival time, average time that they survived after cancer without the recurrence of their disease. For lung cancer was 2 years, 2 years different. If they quit smoking, despite all treatments and everything, they live longer for 2 years without the recurrence of their disease. And that's amazing. When we talk about new treatments, that is very expensive, that is, not accessible, we're talking about months, but this is feasible, this is accessible, this is potential, everyone can do that. And we're talking about, years of increased survival. So it increases survival, reduces the risk of disease progression, and all the things we talked about. So it is critical, and we think that, every patient with cancer at every stage, at every visit should be encouraged to stop smoking and should be supported to stop smoking.
Thank you very much. And you've ended there with, wow, what a powerful message that overall, no matter what stage people are diagnosed or with whatever type of cancer it is, there is a possibility to gain 2 years of extra life if they quit smoking. And as you said, we consider miracle drugs if they can extend life by a matter of months, but 2 years, that's really very striking. And thank you for setting that up for us very clearly at the beginning of our conversation. I'm now going to introduce a number of people who are going to join me on the panel to explore this in a little bit more detail. So welcome to Dr. Dongbu Fu, the Medical Officer for Tobacco Cessation at the No Tobacco Unit at the WHO. Francisco Lozano, who's a patient advocate. He's the chair of Cancer Patients Europe and a representative of the Alejandro de Silva Foundation Against Leukemia. Welcome also to Pernille Gunther, the founder of Focus Patient and member of the EU Cancer Mission Board, and Professor Esteve Fernandez, the director of the Tobacco Control Unit of the Catalan Institute of Oncology. So thank you and welcome. And I have some questions for you in a minute. First of all, I'd like to poll the audience because we have just had really very compelling evidence about why this should be a central element at every interaction between a cancer patient and their clinician, that smoking priority should be part of the conversation, and yet it isn't. So here's our poll for you. We want to know, we've got a statement. Quitting smoking should be a priority for cancer patients and their clinicians. Do you agree with this statement? So were you convinced by that infographic and by the clear messages from Dr. Mahdi Sheikh, or are you perhaps thinking more from a patient perspective, the challenges of dealing with a cancer diagnosis and not taking away the last pleasure they have in life, or their stress coping mechanism? So we'd like to hear from you. Do you think that quitting smoking should be a priority for cancer patients and their clinicians? Should it be right in the heart of their everyday conversations? So I'm starting to see some votes coming in, and so far, perhaps we've been exceptionally convincing in our first messages, but 100% of the people saying yes. Quitting smoking should absolutely be a priority both for cancer patients and their clinicians. The outcome is very clear, the benefits are clear, it should be a priority in that context. And we know already it's a difficult context between clinicians and patients. There's not a lot of time, they've got a lot of complex information to share, there's the need to support people, but the outcome of our conversation here is very clearly that quitting smoking should be part of every single interaction. It should be a priority. So thank you very much. I'm going to close the poll there, and clearly we've got a convinced audience on World No Tobacco Day. 100% of people saying yes, it should be a priority. So I'm going to bring Dr. Sheikh back in. I'm going to ask you, representing the research community, how can the research community make a really strong case? You've already presented some of that, long-term follow-up of trial that you did with patients, but what else can the research community do to make this evidence stronger?
Thank you very much, Tamsin. So as research community, I would say we have several areas to work on or issues to address. First of all, as research community, we should provide the evidence and data for guidelines, for clinical guidelines, for policymakers and everything. So I talked about the studies we did and prospective studies, but these are observational studies. So we didn't intervene, we didn't do anything, we just moved forward with patients. But there is a lot of work that we should do together, and no single institute can do it alone, but a collaborative research should be done. Because, for example, one of the things is to look at other outcomes. For example, second primary cancers. We know that smoking, it has this effect on inducing second primary cancers, and also on the effect of different treatments. And all this data, we need big data, we need collaboration across different health institutes. The second thing, for example, we need interventional studies. So we need studies to assess the impact of integrating smoking cessation in cancer care. So, for example, now there are different modalities for quitting smoking. So I'm just raising the questions that we need to work on more. We know that quitting smoking is beneficial, but so what is the, for example, there are these like nicotine patches, nicotine replacement therapies, there are these like e-cigarettes, there are other treatment modalities. So which one is more powerful, more effective? What is the relapse rate, decrease the relapse rate, and all these questions that we need to work together to answer them. So that's one part, providing evidence and across different types of cancers.
Excellent.
The second part I think we should do is actually, cost benefit analysis, that this is needed, because the governments and policymakers, they would need numbers, they would need to know what is the benefit. And as I said, and as you showed, the treatment failure rate is higher, stay in hospitals is higher, and all this complication higher, and definitely it is cost effective, but we need to do this type of analysis for each country actually to provide this evidence to the policymakers. The third thing I believe is clinical guidelines. We need to many physicians, they do not read papers, they do not come to the do this type of search that we publish, but we need to go to them. We need to include that in our clinical guidelines. We're talking about years. I said 2 years for lung cancer. It is like 3 years for kidney cancer, improved survival, like almost 2 years for head and neck cancers. And we have this strong evidence now. And I personally, I think it is really even not ethical not to include that in management of patients with cancer. It is the most powerful thing. So incorporating that in clinical guidelines, and we need to work with oncologists and other colleagues, and finally policy advocacy. Again, so as researchers, our duty is not only to do studies to provide evidence, but also we need to engage with all levels. And for example, this type of webinar, with patients with cancer, we talk to them, we provide this education, but also for policymakers, we need to do policy advocacy to include that, and to include actually smoking cessation programs in the educational programs of physicians as well. So to deal with that. So engaging with all levels and also providing the evidence. That's what I think we should do.
Thank you very much. Francisco, can I bring you in? And first of all, a warm congratulations, because the WHO has just awarded you a medal for your 2 decades of contribution to the fight against tobacco. So congratulations. Thank you very much. Should we be considering cancer patients to be an underserved community in terms of smoking cessation support? Because this is clearly, we don't have the support, we don't have any idea of what works best for them. And what lessons can we draw from work that's been done with other underserved communities in the type of targeted support they need to quit smoking?
Thank you very much, Tamsin. Well, I first of all would like to say that there's some misunderstanding here. Of course, I think all the levels we must influence and we must explain all the levels of the stakeholders around, all the people around the cancer patient. But I would like now to talk from the side of the patients. And I would like to say that cancer patients, as the general population, want to quit. The smokers want to quit. And that's something that we don't have in mind, because 75% of smokers want to quit. And with cancer patients happens exactly the same. The big problem sometimes is the physicians, all the relatives. The relatives, they say, well, he has a big problem with the cancer. Let's stay with that. But my message from the patients is that we want to quit. Smoker patients with cancer want to quit. I will compare, for instance, with mental health patients. It's very common to see that they die from tobacco and not from the mental health problem. So I think we must try to spread this message to the physicians, first of all, to the relatives, of course. All what you have explained, it was very clear, Tamsin. You explained in the first part of the webinar very, very clear what are the advantages. But probably for the cancer patients, after facing a period with very aggressive drugs many times, if you told them about the quality of life that they will get with quitting smoking, that's something that will give the last impulse to try to do it. So I think the big problem is that many times is not contemplated in the programs of the hospitals, and that's something that must change. Because we look sometimes that the cancer patients say, well, he has too many problems with that. He had a cancer. Don't leave them quiet. But they want to quit as we want to quit as all the. So please let's do as Mandy was explaining. Let's make aware all the stakeholders around us. Starting with the physicians, with all the hospital team, but of course our relatives, because they look at something strange. No. Cancer will be very common in Europe in the next years. We will have a lot of patients with cancer, and most of them will be smokers. So most of them we must have in mind that they want to quit. If we explain them that after their problem with the cancer and with the treatment, they can improve their quality of life, and they will win, as you will earn, as it has been explained, 2 years of life in better conditions. I'm sure they will appreciate if they will help, because we say, I want to quit, but how can I do it? So if you are in a hospital with physicians, please spread this help today. But of course, we must start with all the levels and around us, around the patients. That's my message. Thank you, Darcy.
Thank you very much. And as you say, it's actually an incredibly empowering message to be able to say to somebody who's just had a cancer diagnosis, say, this is the one thing you can do. This is within your power to do, and it will have a huge potential impact on your health outcomes of it. So I think it's a really powerful message to pass. Thank you very much. Let me now pass to Dr. Dongbu Fu. And can you tell us a little bit more? Are there things that the WHO is implementing or supporting that we could adapt or use in Europe to help smoking cessation for cancer patients?
Great, thank you for the question. You know, worldwide we have about 1.25 billion tobacco users. So WHO has been working on supporting current tobacco users to quit as a key component of a comprehensive tobacco control approach. Same, we are supporting countries to implement a comprehensive tobacco control approach in order to help them reduce demand for tobacco and also help them fulfill their obligation to help current tobacco users to quit. You probably heard about a technical package called Empower. This Empower package is the tool we are using to support countries to implement a comprehensive tobacco control approach. They all represent offer help to quit tobacco use. So just say we use this kind of comprehensive technical package to assist country in doing so. So in summary, I would say all the work we are doing is helpful to adapt or implement in European countries. Just would like to give 3 examples. First, we just finished development of a clinical treatment guideline for tobacco cessation in adults. So this guideline includes the recommendations on the behavior tobacco interventions, such as supervised by healthcare providers, intensive behavior counseling offered by National Toll-Free Quit Line, and also the digital tobacco cessation interventions. So this recommendation can guide healthcare providers on how to support tobacco quit using effective tobacco cessation interventions. And then we also contain the recommendation on system level interventions and policies. This is going to inform policymakers and service care providers on how are we going to implementing these effective cessation services. So in summary, all these recommendations and policies can be very useful to be adapted in the country level to help them promote use of effective tobacco cessation interventions to help current tobacco quit. And another thing I think is very helpful is this guideline is going to serve a model to help countries to develop their own national tobacco cessation treatment guideline. Because according to WHO survey, only 40% of WHO member states have their national clinical treatment guideline for tobacco cessation. I mean, in other words, 60% of member states have no national clinical treatment guideline. So they can use WHO clinical treatment guideline as a model to develop their own national clinical treatment guideline. The second thing I'd like to highlight is, WHO has developed a series of technical resources to support countries to develop their national tobacco cessation strategy, policy, action plans, and also scale up the effective tobacco cessation services, such as the one we just mentioned. And the country can use WHO developed cessation service or tools to actually scale up the proven tobacco cessation service at the country level. WHO could also offer support, technical support for them to do that as well. The last thing I would say, WHO also developed a series of technical cessation tools, like you probably heard, like a digital healthcare worker we call Sarah, which able to is an AI-based conversational agency, which you actually talk to her and then you can receive advice on how to quit. We also have like a chatbot installed on many social media platforms like WhatsApp, Facebook Messenger, Viber, etc. All these tools can be used for every tobacco users to quit in all countries, including European countries. That's the things I think very helpful to be adapted or implement in European countries.
Thank you very much. It's very helpful to hear the range of tools, including, some of these new technologies to make sure if you can use a chatbot or an AI, on your phone, in the park, wherever you suddenly are feeling, I need help, that's accessible to you. So thank you very much. And that's talking about how we can, increase the support. So it isn't just at the clinician saying stop smoking, but we've got a range of things that people can do. Thank you. Let me now bring in Professor Fernandez. And we've had set out on that infographic that stopping smoking improves treatment outcomes, but can you help us understand why that is and how does it result in us getting a better response to treatment from patients? You must unmute yourself. Still on mute.
Okay.
That's it.
I thought I was unmuted. Okay, thank you very much for the opportunity to participate in this webinar and try to provide some light on this statement that is perhaps I believe the most important statement from the webinar. Cessation improves the outcomes for any kind of cancer treatment. Any kind of cancer treatment, because cancer can be treated by surgery, chemotherapy, radiotherapy, and in most of cases by a combination of these different techniques, even immunotherapy. According to the type of cancer, we need first surgery and then chemotherapy. In other instances, even the same type of cancer, but different subtypes, it is better to make the chemotherapy first and then the surgery and so on. But the common denominator, the common thing to all of these treatments is that people who don't smoke have better outcomes. They have better outcomes, and the outcomes are better taking into account the time they are abstinent to tobacco. So the sooner the smoker quits, the better the treatment will act. This is very important to take into account, and I will refer to this later. Why cancer patients who smoke have poorest outcomes? Because smoking is interfering the treatments at different levels. For surgery is related, any kind of surgery is related to smoking because the tissues have less oxygen, and the risk of infection, wound infection, and other more general infections are increased in smokers. So perhaps 3/4 of cancer patients got surgery. So this is very important in this case because of the elevated risk of infection after surgery. But also chemotherapy. Chemotherapy depends on how the drugs are metabolized. And chemotherapy can interfere how these drugs are metabolized in different places. Liver metabolism, and in two senses, because cancer patients can have a higher metabolism for some drugs, and this means that the same dose of the chemotherapy that has been proven that works in normal people, in smokers have less effect because the drug is metabolized sooner and the effects are lesser. Or the contrary, that it also a problem. For example, in lung tissues, some drugs are metabolized at a slower speed, and this means that patients can have toxic concentrations of some of the drugs. And this is also a problem because, well, we know that toxicity of chemotherapies is one of the main problems with the treatment of cancer. And this is uncontrolled in smokers. So cancer patients have to quit smoking as soon as possible, even before knowing or having the certain diagnosis of cancer. So when a cancer diagnosis starts, it is very important that at the hospital or the healthcare provider starts with this patient a cessation process. The sooner the cessation starts, the better the outcomes will be. For example, one suggestion that we have put in action in our Cancer Institute is to have a rapid track path for patients in the diagnosis career in order to have them abstinent, if possible, 3 weeks before the starting of any of the treatments, mostly surgery, but also chemotherapy. So the sooner the patient is abstinent, the sooner, the better will be the outcomes. And these fast track processes can be improved because in many cessation clinics, they have waiting lists. You want to quit and you have to wait 5 weeks, 10 weeks to start the cessation process. And we have to avoid this. We have to prevent this for cancer patients or potential cancer patients. So it is very important to start this process. And we know that brief intervention for these patients and complex interventions for these patients are very effective. We recently reviewed the literature on this topic. We published a systematic review in which we demonstrated that intensive interventions, pre-surgical intensive interventions, combining drugs and combining psychotherapy, have an effectiveness between 25 and 35%. So just an intervention before in the pre-surgical consultation, because well, the paper revised in that systematic review were about pre-surgical advice and brief intervention. So it is very important. Why? Because, well, smoking directly interferes with the metabolism, with the oxygenation of the tissues in the body, and also for radiotherapy, this is also true, because radiotherapy also takes into account how the cancer is oxygenized, is related to their surrounding tissues. So it is very important for these biological reasons. And well, patients have to understand this, of course, but I believe, and has been mentioned before, that clinicians have to understand this before, not only after cancer treatment, but the opportunities for improvement of treatment because of cessation prior to the starting of any kind of cancer treatment. This is very important.
Thank you very much. Now let me bring in Pernilla. You obviously have been on the European Cancer Mission board, and we've just heard some really very convincing messages about how important this is. Can you give us some sense of, are there special support packages that or programs that would help cancer patients quit? We've just heard from Dr. Fernandez that they've created special fast tracks. So people, even who are on the pathway to diagnosis, there's a suspicion that there might be cancer, they're fast-tracked in so that when a diagnosis comes, they've already have quit smoking in advance, so you get more effective treatments. But can you tell us, are these kinds of things general across Europe?
No, they are not. I should be very happy to say yes, there are, but it's not. And I think we need to see the consumption of tobacco in some countries are very, very high, and in some other countries, of course, it's quite, if I may use the word, manageable. But if I can bring some examples from my own country, Sweden. I mean, we have had support online, free online support for many, many years. You can call in, or you can have a virtual conversation with someone that can support you to stop smoking, and also counseling within healthcare. I don't think that this is only for cancer patients. It's of course for many other diagnoses. I mean, not the least cardiovascular diseases and cancer have the same problem, so to say, that we really need to make people stop smoking, because otherwise the treatments will not have the great effect that they could have, as we just heard. So I think it's also a public health perspective, actually, to see that, I mean, tobacco also have a relation with other addictions, and we need to make it as or to create it as a public health issue that is important for all, and not to start smoking from the beginning. I mean, it needs to be more natural that you do not start because there are no environment to be smoking in. I mean, we can see a huge change. I've been flying different airports this past week, and I can see, I mean, a huge change from the years where we could see people smoking everywhere, even in airplanes. And nowadays, if someone should do that, everybody should just what, and another example from Sweden is that, I mean, from a patient's perspective, also, if I may bring in that, you can really make an impact. The Asthma and Allergy Association had made a great work to really convince policymakers to ban smoking in public environments. And so nowadays, if someone just should pick up a cigarette in a restaurant, it should be the same effect as you would be smoking in an airplane. No one likes that anymore, because you like to have fresh air around you, and not the least for the children. So I think it's really a change of mindset here, that you really
Yes.
need to do the prevention work as well as of course to help people quit smoking for greater achievement of treatment.
Thank you very much. We're coming to the end of our time together, and it's been a really fascinating conversation. And thank you to both all of our speakers and to the participants who stayed with us. Let me just summarize where I think we've got to today. We began with, I think, Francisco saying, you know what, smokers want to quit. And cancer patients are no different from everyone else. Smokers want to quit. And there is a moral obligation for healthcare providers to respond to that need, to respond to that request and support it. Secondly, the earlier the better to quit, and it's never too late. Nextly is that at the investigation stage, where there's a potential suspicion of cancer, that's the first moment to strike. That's the first moment, because it takes time to put these things in process. We need to have special programs, and possibly fast track and others, that are designed for cancer patients and potential cancer patients, so that they are very clear that this is the one thing they can do. This is the one thing they could do to improve the effectiveness of their treatment. And you know what? I'm sure their families would support them as well, to go and say, this is the news we can tell you. Quitting smoking will make any treatment protocol we offer you better. It will make it work more effectively. And then you engage the whole family in the support. Another key message I've taken is every interaction between the patient and the clinician, the option to provide smoking control support should be there. It should be on the table. It should be part of the regular conversation. We also, I think, have made very clear that, and we've had it described very nicely by Dr. Fernandez, that the biological processes through which smoking interferes with the effectiveness of any treatment, and particularly the more complex sets of treatments that are required. So this should be front and center of the training for oncologists, for all of them. They should know this, and everyone wants the treatment they're offering a patient to be more effective. Well, this is the number one thing you can do, is put that as part of your program. And then finally, I think the good news that for any patient with a cancer diagnosis who is currently smoking, we hear about 50% of people who get a cancer diagnosis are smokers. They could get up to 2 years of extra life. I've seen your hand up, Dr. Fernandez. We've got 1 minute left. Please go ahead.
Yeah, I just wanted to add one thing that we haven't said, but it's very important also to involve relatives and friends in the cessation process of cancer patients. I believe this is a must, because they will help cancer patients to quit, and we will have an added value that other smokers will start cessation programs. So
Yes.
trying to involve relatives to help, to support cancer patients in this is also a key question. I forgot to mention it before. Thank you.
Thank you very much. As you say, you know, when somebody gets a cancer diagnosis, friends and family say, what can I do to help? You know, can I bring you food? Can I take you shopping? The number one thing you could be is be my buddy to help me quit smoking. And I think that's very clear. So thank you all for participating today. I think on World No Tobacco Day, we've had a very clear, very positive message for cancer patients and their families. Thank you for participating. I'm going to close this webinar. A reminder that this and the other webinars are available to watch again. We encourage you to share and distribute without moderation to your colleagues and friends. Thank you all, and goodbye.
Thank you very much.